Great, awesome. Good morning, everybody. Thank you for joining our weekly Monty Hardcast conference. It's a real pleasure to have a good friend, Santiago Garcia, join us. Santiago is now leading structural heart and valvular disease at the Christ Hospital. And since he's been there, I mean, just the work you've been doing has been incredible. Congratulations, Santi. I'm so proud of you and everything you're doing. I think it's amazing, particularly the work you're doing in aortic regurgitation. So we really all excited to hear your update on structural heart disease.
Thank you so much, Yassine. Thank you for having me. Pleasure to be here. I have a very ambitious agenda for the next 45 minutes. I'm going to try to cover a lot of territory. I'm going to get right to it. This is going to be the framework that I'm going to use for this talk. We have 4 valves, and we have a different mechanism of failures, typically stenosis, regurgitation, and 2 ways of approaching this, which is repair and replacement. And my goal in the last 45 minutes is just to give you an update of where we are in each of these spaces with these technologies, repair and replacement. The focus obviously is going to be on transcatheter technology. So let's start with aortic. Aortic is the most mature space. As you know, the 20th anniversary of TAVI has passed just a few years ago. But we do have a lot of activity in the space. We have new transcatheter valves that are coming to market for aortic stenosis. We have indication expansion where we think we're going to lower the threshold at which we intervene in these patients. And then perhaps more importantly and more relevant, we have new transcatheter valves for addressing an unmet clinical need, which is aortic regurgitation. So the first TAVI procedure, as you know, was performed in France in 2002. And for many years, we only have 2 players in the market, the balloon expandable SAPIEN valve and the self-expanding Medtronic. We expect to have 4. The family is going to get bigger very quickly. We already have a 3rd device with a limited indication for high-risk patients. That's the Navitor, formerly known as Portico. And then we're expected to have a 4th one, hopefully at the end of this year or early 2025. This is the Accurate Neo2 valve. As you can see, it's a self-expanding nitinol stent that comes in 4 sizes. It can treat a variety of annular anatomies. It relies on this upper crown to capture the native leaflets and has this relatively large stabilization arches that will facilitate coronary engagement. It has minimal protrusion in the LVOT. It has a very interesting mechanism of sealing, similar to what was present in the Lotus valve. The pivotal trial has completed enrollment, and we're expecting results hopefully this year with approval, as I said, for 2025. The procedure cadence is fairly straightforward. It really relies on putting this marker at the bottom of the pigtail and the non-coronary side. It's a 2-step procedure from top to bottom. First, the stabilization arches are released, and then the stent holder is advanced forward, and the valve is functioning. It really it has the feeling of a balloon expandable TAVI, and I think we're all very excited about having this technology in our hands on the commercial side soon. The second valve, it's already in the market in the US with a limited indication for high-risk patients, and then Asim Latif will be actually leading this trial in the low and intermediate risk patients, and hopefully it will come to market in a few years. But this is another self-expanding valve that has very interesting features. You can see this very large cell design that can allow not only engagement of the coronaries, that can facilitate perhaps in the future valve-in-valve procedures. The seal, the Navi seal, has also mitigated one of the perceived weakness of this device in the first generation, at least, which was PVL. Now it has both an inner and an outer cuff, and it has now 4 sizes that can accommodate a variety of anatomies and annulus up to 30 millimeters. This is going to be, I think, one of the main advantages, which is coronary access will be unimpeded by the frame of the stent. You can see multiple guides can be accommodated inside one cell, which is, I think, a significant improvement relative to the existing technologies that we have. On the balloon expandable valve, there has been progress too. The SAPIEN X4 is now being investigated in the Alliance trial, which has 3 arms. There is a native aortic valve stenosis. There is a valve-in-valve arm, and a 3rd valve that is hopefully going to launch soon, a mitral valve-in-valve arm. This valve has 3 features. that are novel relative to the SAPIEN 3 platform. One is that it has adjustable valve sizes that increase at 0.5 millimeter increments. So that can be, hopefully could allow more personalized treatment of patients that are in between sizes at the moment. The second one is commissural alignment, which is probably the most notable. This is relatively easy to do, and I'm going to show you how it's done intra-procedural. And the third one is Resilia tissue, something that otherwise has been doing on the surgical side for a number of years with good results, and now it's coming to the trans catheter side as well. It's probably going to be present in all their platforms. And so the number of valves will remain the same, but the possible combinations will go from 4 to 16, and that is done by modifying the configuration of the stem frame, still cobalt chromium, but has a different configuration that can essentially treat multiple sizes at 0.5 millimeter increments. In the trial, the operator is no longer in control of how much volume it goes in. This is a very prescriptive formula based on the CAT scan, so you can treat a variety of anatomies, hopefully leading to better outcomes, less annular rupture, and maintaining the excellent safety of S3 in regards to PVL. This is how commissural alignment looks like. There is a C that has to be facing to the right. This is actually a tab degeneration, so this is an X4 inside an S3. And it allows for essentially alignment of the commissures either with the native anatomy or with the existing valve. And this can be rotated with a knob on the catheter, so it can be done while the device is in contact with the anatomy. There's no need to pull the delivery system back to the descending aorta to do commissural alignment. What about indication expansion? We know that many quote-unquote asymptomatic patients actually have symptoms, and about 50% of them will fail at treatment if given an opportunity to walk or exercise. These are patients that are frail, come to the appointment in a wheelchair, and I think we're trying to delay interventions. We're trying to delay these emergency landings where we see them for the first time in the emergency department. So that's one, the asymptomatic aortic stenosis population. And the second one is moderate aortic stenosis. We know that aortic stenosis is not only affecting the valves, but it also affects the heart. So we're now evolving into thinking about aortic stenosis the same way we think about cancer, where there are stages from 0 to 1, 2, and 3, and 4, depending on whether there is impairment of the LV function or LV remodeling, atrial remodeling, such as atrial fibrillation, or pulmonary hypertension or right ventricular involvement. So for those patients who perhaps have moderate aortic stenosis but have evidence of cardiac damage, we may be able to offer intervention. There are 2 trials that are ongoing. First one, early TAVR trial, this has completed enrollment, and hopefully the results will be available soon. This has a 2-year follow-up for the composite endpoint. This is essentially randomizing patients with severe asymptomatic AS to a transfemoral TAVR with a balloon expandable valve versus clinical surveillance. And the primary endpoint is going to be a composite of all-cause mortality, stroke, and planned cardiovascular hospitalization. This is going to be an exciting trial that, if positive, may change the guidelines. It may allow us to go directly from the echo lab to potentially a procedure without taking into consideration symptoms. The second one is the PROGRESS trial, and there are two versions of this. This is for the balloon expandable valve, but there is another one also for self-expanding valves targeting patients with moderate aortic stenosis. They will be randomized to TAVR versus clinical surveillance, and it will have a very similar endpoint at 2 years. In particular, the focus will be on heart failure hospitalizations. So moving on to now aortic regurgitation. We know there are challenges in treating aortic regurgitation that are not present with aortic stenosis. And the first question is, why do we need transcatheter valves that are different? Because the main answer to that question is that we don't have calcium, and most of the devices that we use on the TAVI side rely on calcium for anchoring. Patients with aortic regurgitation have little to no calcium, and therefore they're at risk of valve migration, which tends to be a catastrophic event, usually leading to surgery. So we have 2 technologies now. One is ahead of the other one. This is the JenaValve, the Trilogy system. Both technologies relied on the same mechanism for anchoring, which is capturing of the leaflets. Think of it as a paper clip, where these locators, in the case of the JenaValve, are positioned at the bottom of the coronary cusp, and then the valve is essentially unsheathed inside the native anatomy to capture the native leaflets. This is a valve that it's constructed of porcine pericardial tissue. It can treat anatomies from 66 to 90 perimeters. There is a requirement for aortas not to be too horizontal, so 60-degree angulation is the cutoff was the cutoff for the clinical trial. And this is a 20 French device. The sheath is pre-shaped and it sits in the ascending aorta, so it goes all the way up. As you can see on the left, there is a catheter deflector, so these locators can be rotated in one direction or the other. We spend quite a bit of time looking at this on fluoroscopy to make sure that each locator is in the respective cusp before the valve is expanded. The procedure can be broken down into 3 steps, which is alignment, positioning and anchoring, and then valve deployment. And we spend quite a bit of time in number 1 and number 2, making sure that these locators are aligned with the native anatomy. After that's done, then the stent holder is advanced and the valve is deployed. The results for the ALIGN-AR trial have been presented at TCT last year, and as you can see here, they're excellent. There was 0 intraprocedural mortality, annular rupture, or coronary obstruction. This is really remarkable. The technical success was very high, close to 100%, and all-cause mortality at 30 days was in the very low single digits. The issue that remains, I think, is the need for pacemaker, which is in double digits, upward of 20%. It has gotten better in the trial. So if you look at the last part of the trial, it's in the mid-tens versus the first part of the trial. So I think we're understanding more where to position the locators, and appreciation that they don't necessarily have to go all the way down to the cusp to be able to capture the leaflet. So more to come on that, but at the moment, that appears to be the main limitation of this technique. This is a case from our site looking at these very difficult patients to treat, those patients with LVAD and aortic regurgitation. As you know, about 40 to 50% of them will develop severe AR after 3 to 5 years of support, and there is no valve that can treat those patients commercially. You can see this was a very effective procedure, a complete elimination of aortic regurgitation. So more to come on this valve, but we're excited to have this device hopefully in the market by the summer. A second device that is a little bit behind in terms of regulatory approval is the J-valve. It's a transfemoral system. It has some advantages. It's a steerable, flexible catheter that has 2 knobs. There is a yellow knob that controls the anchor rings and a gray knob that controls the valve deployment per se. It comes in 5 sizes. It can treat anatomies up to perimeters of 1 of 4. So it certainly has indications for patients with large annuli. And unlike the Genovalve that has a pointy locator, this has a U-shaped anchor rings. So in general, when these anchor rings are expanded in the ascending aorta, they tend to naturally go to the respective sinuses. The sheath, it can certainly be done with an expandable sheath, and we have done cases with just the E-sheath, so we can keep it to 16 French. Otherwise, if it's not an expandable sheath, you will need an 18 or 21 French, depending on the size. And there is no limitation for horizontal aortas, as you can see in this case. The 3 anchor rings are deployed first, and then the stent holder is advanced. We typically use rapid pacing for this part, but it's not mandatory. The stent holder is aligned with the top of the anchor rings, and then the valve is deployed, usually resulting in complete elimination of aortic regurgitation. We finished the early feasibility study and will be presented at CRT, and we're having conversations with the hopefully we'll be launching this pivotal trial in the summer. This is going to be the name, the Journey trial, and it's going to be based on a performance goal, single-arm study. Every patient will get the transcatheter device. We're looking for high-risk patients that are not candidates for surgery. The primary endpoint is going to be 1-year mortality, and there will be a safety endpoint at 30 days based on BARC-3 criteria. There are 2 novel aspects of this trial. One is that we're going to allow a cardiac MRI to be used in those patients that have grade 3 to 4 AR or uncertain AR. We want to make sure that we capture those patients based on cardiac MRI, which is what guidelines recommend. And we're also going to allow patients that have unclear symptoms to enter into the study if they don't pass a treatment, so similar to the early TAVR approach. This is going to be the design of the study. We will rely heavily on American Society of Echocardiography criteria, but also cardiac MRI for better volumetric assessment. And we will allow for a stress test for patients who have unclear symptoms. So potentially could have an impact on guidelines as well. Moving on to mitral regurgitation. We know this is way more complex. We have multiple phenotypes with different thresholds for interventions. We have primary MR where the problem is in the leaflets, and we have secondary MR where the problem is usually in the neighborhood, either the atrium, the annuli, or the ventricle. And then the Carpentier classification, which allows to identify subsets that are really hard to treat, like the Carpentier type 3A, usually patients with MAC, for which we really don't have a great surgical or transcatheter solution yet. The standard of care for those patients with primary MR and acceptable surgical risk continues to be surgery, most commonly a triangular resection of the posterior leaflet with an annuloplasty ring. But there are many patients that are not good candidates for surgery, or they have functional MR. And those are patients now that, in light of the co-op trials, are better served by a transcatheter solution, in particular edge-to-edge repair, as stated in the most recent iteration of the guidelines. And this is based on the co-op trial that shows superiority with regards to mortality and heart failure up to 5 years when compared to optimal medical therapy. Now, mitral regurgitation is undertreated in part because not everyone is a candidate for surgery or transcatheter solutions, and this is how we tend to look at TEER. We have anatomies that are straightforward for TEER, and those patients usually are a no-brainer. We offer that first, but we have more complex anatomies that are unsuitable for TEER at the moment, and these are despite our best efforts. We have now the fourth generation mitral clip, which has multiple sizes, allows for controlled grasping actuation and continuous left atrial pressure monitoring. This has certainly improved the results of TEER. As you can see now, 90+% of patients are expected to leave the cath lab with mild or no mitral regurgitation, significant improvements in quality of life. 82% will have class 1 or 2 heart failure symptoms at 1 year, with meaningful improvements in the KCCQ, close to 20 points. And so definitely the technology is getting better. And now we have a second player with a Pascal device, which has some important features. It has a spacer, which is absent in the mitral clip device, and has only one row of frictional elements, which is thought to be more gentle on the leaflets as well. And this has received regulatory approval for patients with DMR in the United States. There are, however, anatomies that are simply not suitable for TEER. And those anatomies can be broadly seen as fitting into one of these two categories. Those patients who are at risk of iatrogenic mitral stenosis, these are patients that have typically MAC or small valve areas, elevated gradients at rest. And the second group are those patients with multiple jets that are at risk of inadequate reduction of MR with mitral TEER. And those are the patients that have been the focus of TMBR devices. And the problem with TMBR devices is that very few patients actually qualify in the pivotal trial. So the screen failure rates is a big frustration for all of us, and I'm sure Asim shares that frustration with me. 80 to 90% of patients we submit to the sponsors come back with a no. And the number one reason for that tends to be anatomical, usually a combination of LVOT obstruction or predicted LVOT obstruction or inadequate size matrix, either the annulus being too small or too large for the device. So we definitely have challenges and potential solutions, but it has been a slow, painful road to finding the ideal TMBR device. And this is one of the concerns that we have with these technologies, is that unlike surgery, we do not remove the anterior leaflet. The anterior leaflet is pushed to the side and can certainly cause problems in the left ventricular outflow tract. We would obviously try to avoid and predict the best we can with CT. These are the systems. I think if you had seen this slide 5 years ago, there were over 60 devices. Just not all of them obviously are going to make it to the finish line. It's very costly. The ones that I'm going to be discussing are the ones that are most advanced in phase 3 clinical trials, and those can be seen here. There are transapical systems and transeptal systems. And I'm going to start with the transeptal Apollo system. This started as a transapical system, but has evolved now into transfemoral. and hopefully will be reduced to 29 French soon. This device comes in two sizes. You can see it has a dual stent configuration. There is an outer stent that tends to conform to the anatomy, and an inner stent where the valve housing unit resides. This is the same stent for both sizes. It's a 27 millimeter stent. And the valve can treat anatomies from about 100 perimeters to perimeter of 134. It's bovine pericardium and relies on the cork effect and small cleats for fixation. Is 35 French system. As I said, it will come down to 29, and hopefully we'll see less issues with atrial septal defects once we get a profile lower than 30 French. This is the pivotal trial, which is ongoing. The Apollo trial, it has two arms. The primary cohort, which is looking at patients with moderate to severe mitral regurgitation who are not suitable for surgery or TEER. This is almost 50% enrolled at the moment. And then there is a MAC cohort. This arm of the study accepted patients who have mixed disease. A combination of mitral regurgitation and mitral stenosis, but it has to be MR in order to qualify for the study. This is a procedure in a patient who has a previous TAVR device. There is a piston that is advanced by inflating the catheter, and the valve is essentially exposed. And this is a patient that we treated with mitral aortic calcification. As you can see, for those patients who qualifies, the procedure works really well. It's a very effective therapy. So the challenge is not so much to refine the delivery system, is to find those adjuncts, procedural adjuncts that will enable this therapy to be applied to a broader patient population. And this is what typically what we see post-procedure. There is no to very little MR. The second device that I'd like to discuss, also in phase 3 clinical trials, is the Encircle device. This is also similar patients with mitral regurgitation. There are 3 arms in this study, the Encircle study. The main study is complete in terms of enrollment. We're now looking at the 1-year follow-up. Enroll 300 patients with severe mitral regurgitation, whether it's functional or degenerative. There is a failed TEER registry for those patients who had an attempt to repair the valve, but the attempt failed, and there was no device left behind, but there was a transeptal performed. And then finally, there is a MAC registry for patients who have mitral aortic calcification. The technology relies on the SAPIEN 3 system, which you can see is a little bit different in that it has a big PTFE skirt that goes all the way from top to bottom. And then the novel aspect of this device is this SAPIEN M3 dock. So this is a 2-stage procedure where the dock goes first, and then the device goes inside the dock. At that point, it becomes like a mitral valve ring procedure. There is a one-size device fits all type of solution. So this is a 29 SAPIEN 3 with a woven PAT outer sealing skirt that covers the entire length of the device. The dock has 3 kinds of turns. There is an atrial turn, there is an encircled turn, and then you have 3 functional turns with a PBL guard. This is the most recent iteration of the dock. The PBL is there to mitigate paravalvular regurgitation, which tends to occur usually in the medial commissure. This is sort of some of the animal bench model. So you can see how this dock looks from the atrial side and how it looks from the ventricular side. This is the challenging part of the procedure, is to encircle all the subvalvular apparatus. And this is obviously guided by transesophageal echo and fluoroscopy. And this is how the procedure cadence works. So once we perform the transeptal, we advance the dock delivery system, usually engage the medial commissure, and then from that point on, we start to encircle. Most of the time, this is the part that can take as little as 10-15 minutes, or as much as 1 or 2 hours, depending on the anatomy. Once this part is complete, this can be released. And from that point on, this becomes a valve and ring procedure, where the SAPIEN valve is deployed inside the ring, usually with the marker aligned immediately above the dock. There is a mandate for post dilatation, usually with 2 cc extras after the valve is deployed. And in those patients who qualify for the study, again, the results are very predictable and tends to work very well, similar to a valve and ring procedure. Finally, I'm going to talk about Tendyne, another technology that we're involved in. It's a transapical device, but it's also far advanced in terms of clinical trial testing. It's already approved in Europe. It comes in multiple sizes. It's a very effective device. It eliminates mitral regurgitation. The problem is that most of these patients have very high mortality in 1 or 2 years, up to 42% in the early experience. Whether that's related to the transapical access to the kind of patients that were included in the clinical trial remains to be seen. But certainly, this is a technology that we're going to have commercially in the United States soon as well. The pivotal trial, the Summit trial, also has multiple arms. Interestingly, the pivotal trial is randomizing patients to Tendyne versus mitral clip. So these anatomies that have to be suitable for either procedure. There is also a single arm registry of patients with MAC that is also close to finishing enrollment as well. So that's the update for mitral. More to come, hopefully in the next few years. Tricuspid, this has been known as the forgotten valve. It's not like really we forgot. I think we just had a complete misunderstanding of what the valve does. Historically, it has been considered a passive structure with no meaningful function. Our surgical colleagues used to believe that fixing the mitral valve will automatically lead to improvement in tricuspid regurgitation, and has been disproven more recently in clinical trials. This slide was changed a couple of weeks ago. We had received now regulatory approval for one device, which is a very important milestone in the United States. We have now the Evoque system by Edwards commercially available to treat patients. And today, the second device, the TriClip, is going to go to FDA panel. So more to come on that, but this landscape is changing very, very quickly. So far, we have one clinical trial, Triluminate, that has been published, and that has shown improvements in quality of life. The Evoque data has been presented up to 6 months, and it looks also very encouraging in terms of TR reduction and quality of life improvements. So this is the first device, the TriClip. As I said, they're going to go to panel today, so stay tuned. I may receive commercial approval by the FDA. This is a pivotal trial leading to that panel, randomize patients to the TriClip device or best medical therapy. There were very strict enrollment criteria for the trial. Most patients had to have gaps that were less than 10 millimeters, and they had to be on optimal medical therapy and had a right heart cath to document that as well. The results of the trial were mixed. I think in terms of hard endpoints, there was no effect on death or need for tricuspid valve surgery, no effect on heart failure hospitalization, but there was an improvement in quality of life, which was part of the composite endpoint. So overall, the win ratio was favorable for the device, 1.48. As you can see here, the event rates were rather low. I think if you ask most of us prior to Triluminate what the mortality was for patients with tricuspid regurgitation, most of us would have said double digits. I mean, we had the VA study showing 1-year mortality of 36%. Triluminate taught us that actually is significantly less than that. It was about 10% combined with the need for tricuspid valve surgery. So 8 to 10% hard endpoints in 1 year, which is relatively low when compared to registry data. The annualized rate of heart failure hospitalization was also fairly low. Historically, it has been about 1 per patient per year, and this was significantly less than that. This study was done during COVID, so that might have affected that. But nonetheless, at the end of the day, the only signal in favor of the device here was the KCCQ, which was favorable for the device. A change in more than 15 points was achieved in almost 50% of patients with the device versus only a quarter of patients with medical therapy. Surprisingly, there was no difference in the 6-minute walk test and other measures of quality of life. They usually go hand by hand. This is the effectiveness of the device in terms of TR reduction. As you can see here, is moderately effective. 50% of patients still leave the room with moderate to severe tricuspid regurgitation, and this may be a limitation of the technology, not so much of the device. I think we'll see what the Pascal trial shows, but most of these patients have wide gaps across the coaptation line, and this is perhaps something that we need to better understand. What's the role of repair versus replacement? But this is certainly not something that goes without saying. That is not an ideal result. The Trilumina trial showed very clearly there is an association between quality of life and TR reduction, which brings me to the next device, which is Evoke. As I said, this has received regulatory approval recently in the United States. It comes in 3 sizes. The 56 was available in the last part of the trial, will not be available commercially for a while until the FDA gives approval. But we have these 3 sizes, 44 to 52, can treat a wide range of anatomies. It's a 28 French device, completely transfemoral, has 9 anchors that had to interact with the anatomy, had to capture the leaflets for fixation, bovine pericardial tissue, and it's a 19-hole self-expanding stent. We have seen the results for the 6-month primary effectiveness and safety outcomes of the device presented at TCT. This is just 150 patients. The total cohort has 400 patients. This is something that the FDA has seen, but we have not seen yet in publication. But we're optimistic that if the FDA has given approval, we're going to see very favorable results in terms of heart failure, hospitalizations, and mortality. What we know so far is that at 6 months, the device is very effective in reducing tricuspid regurgitation. Almost 94% of patients have no TR or mild TR. So this is significantly improved relative to H2S repair. 90% of patients have New York Heart Association functional class 1 or 2 heart failure. And unlike H2S repair, there is a significant improvement in walking distance, which I think is a meaningful endpoint for these patients. The win ratio, which this is a similar concept, has clearly favored the device up to 6 months, and we have to see for the 1-year data, but you get a clear sense for where this technology is going. Improvements in KCCQ, improvements in functional class, and improvements in 6-minute walk tests. At 1 year, we will be seeing heart failure hospitalizations and mortality for the 2 groups. This is the procedure, which relies both on fluoroscopy and transesophageal echo guidance. This is a typical result for a patient, severe or torrential tricuspid regurgitation, and that is completely eliminated after valve replacement. This is not an outlier. This is what most patients look like after this therapy. Pulmonic. This is also something that we typically don't talk about. I do have an interest in congenital heart disease. There are 3 substrates, which historically we've been able to address 2 with transcatheter therapies. Those are the valve-in-valve patients and patients with omograph. The 3rd substrate, the patients with the native RVOT, those patients that have received usually tetralogy of Fallot, enlargement of the outflow tract, but no valve replacement. They have been difficult to treat. These patients are left with severe pulmonary regurgitation, and by the time they get to us, they tend to have very large anatomies. Now we have 2 devices that have received commercial approval in the last 3 years, Harmony by Medtronic and the Altera device that allow us to treat most of these anatomies. These anatomies historically have been challenged, very challenging to treat because they're highly variable. The type 1 or pyramidal RVOT is the most common one. It's a very pulsatile structure, as you can see, and the devices that we had commercially before Harmony and Altera typically did not provide reliable anchoring. There is a very poorly defined landing zone, and there is lack of calcium. That has changed, and these 2 devices have really changed the game. Harmony is a 1-step procedure. It's a self-expanding 19-hole frame. It's long, it's 55 centimeters long, so you have an outer stent that accommodates the native RVOT. And then there is a valve housing unit at the middle of the valve that has 2 valve sizes, 22 or 25. It's a 25 French delivery system, and the procedure essentially looks like this. There is a nose cone that is advanced usually into one of the PA branches. And then the device is unsheathed and as guided by pulmonary angiography. And typically the result is like this. There is complete elimination of pulmonary regurgitation. The second device that has received commercial approval is the Altera valve. This is by Edwards. It's a 2-step procedure. First, the Altera pre-stent is deployed, and then inside, in the valve seating location, the SAPIEN 3 is deployed in a second step. This is also a tall stent. It's 48 millimeters, has a flare inflow and a flare outflow. Can treat anatomies up to 40 millimeters, which is something that we couldn't do before. And as I said, this is a two-step procedure. Once the Altera stent is deployed, it has markers in the valve housing unit that allow us to position the sapien valve and deploy it, usually without rapid pacing inside it. And again, very effective way to eliminate pulmonary regurgitation. And so, well, we are today in 2024. Sorry, it's not 2004, 2024. We have devices in green that are approved in the aortic side for aortic stenosis. This has been the case for now over 20 years. But soon we're going to have devices that are approved for replacement in patients who have native aortic regurgitation. For mitral, we have repair options, and we're hopeful we will have replacement options that are commercially available soon. For pulmonic, we have replacement options. For tricuspid, we have replacement options. And hopefully today we have repair options. So I think it's fair to say that we have made significant progress in the treatment of valvular heart disease with transcatheter devices over the last 20 years. With that, I will conclude and we'll open up for discussion. Thank you again for having me today.
Wow, Santi, that was fantastic. It was really an overview of the current sort of state of the art of where we stand with valvular disease. It was really phenomenal. Thank you so much. I think, I'm sure our faculty and audience were blown away as much as I was with the presentation, because I think if you're not really in structural heart, this is really an amazing overview. I don't want to keep you for much longer. We love to have the fellows and faculty ask a few questions at the end. So if you don't mind, we'll give you a few more questions and then we'll let you go. Is that okay?
Absolutely, absolutely.
So Andre, I see you on. You want to start, and then we'll go to Saul and Manaf. And if there are any other questions, if you want to either raise your hand or I can let you chat or put it into the chat. Feel free to, please.
First of all, thanks for this this talk. You really covered everything in the structural space. I was very interested to hear from you, which is your opinion on the tricuspid space. With the Evoque being commercially approved, we saw very promising signs, particularly for the 18 months improvement in survival, at least the trend that led this FDA approval. How do you think the tricuspid space, including all the ongoing trials, will change in 2024 after this approval from the FDA?
Yeah, I think the bar has been set very high with the Evoque. As I show you, there is complete elimination of tricuspid regurgitation. I think that's perhaps is the most important lesson from Triluminate, which is there is a nice correlation between quality of life improvements and TR reduction. I think there will be room for more than one device, but it's clear that all of us are developing a clear bias, and my own bias is that I tend to favor replacement. We have access to both technologies based on the results and the ease of use. I think it's fair to say that the Evoque or valve replacement in general, I think is going to be the predominant treatment option. But you have to also remember that TR begets more TR, and there will be patients that present early on that we can potentially offer solutions, whether it's H2S repair, leaflet treatment, annular reduction, and so forth, to try to mitigate this. And I think we're going to have to think about this very different than the way we approach aortic stenosis, where we move from high-risk patients to low-risk patients, and now we're going to indication expansions. I think the window for treating these patients with leaflet technologies and annular devices is going to be in patients that perhaps don't have these torrential TRs. They have more moderate to severe TRs where the coaptation gaps are not super wide. Once these patients have wide coaptation gaps, I think replacement is probably going to be the way to go, unless they're too far gone when you have right ventricular dysfunction and you have concerns about how that ventricle is going to tolerate that afterload of the pulmonary artery. So it's, I think, a more physiologic approach rather than a surgical-based approach. I think there is not much of a role for surgery. If you look at the trials that we're discussing, all of them use medical treatment as the comparison arm. So we're going to have more than one device. I think for the majority of patients, it's probably going to be a replacement, in my opinion. but there will be a role for other devices probably early on in patients who have less severe forms of tricuspid regurgitation. And these are the patients that were included in the clinical trials. I think the EVOQUE patients are probably very different from the TriClip patients.
So, I mean, in your own center, Santi, say TriClip's approved, and now you also have Evoke. What is your algorithm going to be? Are you going to, you know, uh, equally treat patients with clip versus Evoke? Are you, you know, because in Europe, most centers are tier first, right? So they'll try and do tier, or they'll see if the patients can do tier, and if they can't do tier, they will then do replacement. They see replacement as a solution for patients who can't undergo tier. What are you going to do in your center?
I think we're probably going to have a different approach in my center and probably in the United States. I think it's going to be replacement first mindset, just by the virtue of the patients that we see. I do bring all the TR workups with the transesophageal echo, and I personally look at it before I make a decision as to whether we're going to go in one direction or the other. And the things that make me think replacement are if I see gaps that are more than 10 millimeters, if I see gaps that or TR jets that go anterior posterior across the coaptation line, where you're thinking, even if I can successfully put two devices, I'm still probably going to end up with residual TR. I don't want to leave the room with moderate to severe TR. I do think that eliminating TR should be the goal, and
Absolutely.
that with that mindset, I think replacement is more effective than edge-to-edge repair.
So
This is not to signify there is no role for edge-to-edge repair. I think there
I
is.
agree. Listen, you're speaking to the converter, but I'm going to put you on the spot a little bit. So the patient can have both tier and replacement. The gaps are 6 millimeters. Okay. They can have either. They're suitable for good result with either. In what is Santiago Garcia going to be doing 6 months from now?
In a patient who can take anticoagulants, I will probably be offering EVOQUE first. Yeah.
Okay. Yeah, that's what we're going to be doing too at Monty. That's how I feel too, and it's exactly what you said. It's just the reproducibility of the procedure, and the fact that you end up with no TR at the end. My only worry is, thrombosis. I don't know about you, but we've had a couple, so that worries me a little bit because it takes a while to get rid of it. But yeah,
I think the 2 points, just to convey the audience a fair approach to this, the two things that we have learned in the EVOQUE experience so far, the two complications in double digits. One is bleeding, which probably relates not so much to the device, but to the need for anticoagulation to try to mitigate thrombosis. It's about 10% of patients. And then the need for pacemakers, which still in double digits, the AV node is right next to it. And we still need to know how to manage the leads. And, the new member of the heart team is going to be the electrophysiology partner. We need to manage the leads upstream and downstream because people come with leads and sometimes they leave with leads after the procedure. So,
sure. Saul, did you have a question? Or Manaf?
Yeah, thanks for a great overview. I just wanted to get your thoughts on how you think we're going to be dealing with this increased inflow of TAVR patients who are getting increasingly implanted in larger and larger numbers as they get older and their valves degenerate. And we are going to be forced to do a lot of valve TAVR and TAVR. What do you think are going to be the important considerations for those patients and technologies that may kind of change our ability to do this procedure? Do you think we're going to have to figure out a way to remove old leaflets? Are we just going to have to get better at valve design? Does that need to change? I'm just curious about your thoughts.
So I think it's my thoughts have evolved on this. So let me tell you where I am right now, and they continue to evolve. I do think we have to look at the patient very carefully. I think we're overusing TAVR in very young patients. That's my number one concern, which we're pulling the trigger at ages that you can predict the patient is going to need multiple procedures. Having said that, the trend for bioprosthetic valves has affected both TAVR and SAVR, and that's not going to change. People don't want to take anticoagulants. So we're going to have to figure out how to treat patients that present with bioprosthetic valve degeneration. We learn how to do that with surgical valves, and I think we don't think much about it, and we have to learn how to do that with TAVI valves. I think when we look at our experience in the last 10 years, and the number of patients that have come back and needed a repeat intervention has remained in the very low single digits. And what tends to drive the second treatment is the indication and the mode of failure. So the patients that need a TAVR procedure are the ones that have infective endocarditis. And that subset, I think, is going to be hard or impossible to treat with a repeat TAVR procedure. The patients that have structural valve deterioration in general, we can treat with a repeat TAVR procedure. And I think, as you said, it's going to get better, and we certainly cannot treat everybody, but it's going to be, I think, a matter of figuring out procedural agents that allow a more systematic approach to those patients. We're going to have to learn how to live with it the same way we learn how to deal with degenerative surgical valves. So I think it's going to be very doable for at least the first procedure. And then we just have to get smarter and develop procedural actions that enable these procedures. You know, we talk about lifetime management of aortic stenosis, and when the congenital guys look at us, they laugh because we start at age 65, at 70. They start when they're babies, and they do it very well. They work with the surgical colleagues. Most of the procedures that we do are not going to be curative forever, and we have to learn how to innovate and maintain that cadence so that we can keep these patients alive with repeat procedures. I don't think we're going to go back to mechanical valves, but we need to be thoughtful about how we frame the conversation, and perhaps starting at age 50, 60 is not very wise. But I think enabling 1 or 2 procedures down the road is something that is a reasonable aspirational goal at this point.
I think that makes a lot of sense. Yeah. And I think, I found that as I'm seeing more and more patients who are younger, I'm actually sending more patients to surgery recently than I was in the past. Because before it was just all, high risk patients and elderly. So I had to do something. Whereas now, you have to start being more selective based on whether you can give them a good outcome. But more and more, I'm trying to predict, can I do a second valve in them? Can I do TAVR and TAVR?
No.
And if I think I can't do TAVR and TAVR, then there's no point, for me in a young patient doing a TAVR as their first option.
Agree.
There's one really interesting last question from Saul, which I'm interested to hear your opinion. So Saul was asking in the chat, he was saying, regarding the treatment of MR and transcatheter options, do you think there is any role for annuloplasty?
The answer is yes. I think we need to learn that, right? And I think you were involved in the Millipede experience, and there was a lot of enthusiasm, and that has sort of faded a little bit. But I think if you look at what we try to do in the mitral space, is usually based on a surgical predicate, and I think the surgeons will typically leave a ring behind for a reason. I think cinching that ring in patients who have both DMR and FMR, it's important, and we just haven't figured out how to do it in a way that is consistent, reproducible, and efficient. I hope that the Cardiovan program, it's going to come back, and we will have options hopefully soon. But my personal sense is that there is a role for transcatheter repair of the annulus, and you can see this interest in technologies that are both intraannular or also extraannular, that try to modify the coronary sinus to reduce the size, both in the AP dimension and intercom. So I personally believe in the concept. At the end of the day, I think it's going to be ease of use, and if this is a procedure that takes 3-4 hours to do, probably will not be applicable to most centers. Right. But hopefully we will develop a way to do it in conjunction with TEER or soon after TEER in those patients who need it. I think for functional MR is going to be important.
Great. Santi, thanks so much. This was phenomenal once again. I really appreciate you taking the time. We all learned so much from you. I'll see you soon, my friend.